I'll start by thanking all of you for coming, and thanks to the organizers for inviting me. I've got a little bit of a cold, so please bear with me. Slides up yet? No? Great, good. And do I advance it with this? What? The green? This one. Okay, good. Terrific. Good. All right. I'm an opponent, actually, of this practice, so I'll be clear about that. I'm a general internist and a philosopher, but I've also been practicing social science without a license for quite some time, and not really someone who has studied this subject empirically. So what kinds of contributions might I make today? I thought that they might be actually methodological, and especially talking about the relationship between empirical research, policy, and ethics. I actually have written with Jeremy Sugarman a book on this topic, and a lot of what I'm going to do is just sort of basically applying principles from that book straight to the questions that are before you today about this empirical landscape of physician-assisted suicide. So whenever one engages in empirical research about a controversial medical practice, you have to ask some questions. One is, what do you hope to learn and why? I mean, why are you even taking this up as a topic? Opponents, of course, are going to look for evidence of abuse. Proponents look for signs of reassurance or extra information that will help people gain access. One has to think, I think, about some of the ways in which personal and political views can even suppress the kind of hypotheses that one generates. For instance, one can read in the Canadian medical literature a recent cost analysis of medical assistance in dying in Canada, while if you talk to people in the United States, even bringing up the topic that there might be some relationship between cost containment and this becomes inadmissible for discussion. So it's just a question that inquiring minds would want to know is why is that the case? And in taking up any question for empirical research, the ideal is always a dispassionate, disinterested desire to know as the scientific ideal. So then I would ask, why has this topic been taken up by the National Academy of Medicine as worthy of a workshop like this? If the mission is critical issues in health, medicine, and related policy, what makes this critical? It's probably not a public health crisis if, as you've heard, so few people, at least in the United States, are actually doing this. Good arguments can even be made that this is a distraction from improving health care for our aging population, the sort of demographic tsunami that we're about to face. And if you begin, as it seems to me that folks are here, to take a sort of health services approach to this question, think a little bit about the premises that are even embedded in taking up that approach. It sort of presumes, as I think you've already begun to hear without argument, that the goal is a good one. And then the bad, once you're in the health services research mode, simply becomes assessed in terms of efficacy, safety, cost, and access. Those are all contestable ethical assumptions that are already deeply embedded once one begins down this course. Think about the composition of the panels in this workshop. Some of you may be aware that even the composition changed from a month ago until now in a way that even has anybody like me who is actually in the least bit really significantly opposed to these practices. If one is interested in a disinterested scientific approach, why is that the case? And there are some potential upshots to having a conference like this, whether they're intended or not. One of which I think is just normalization. right? This becomes seen as a subject worthy of the National Academies of Medicine to take up. It becomes medicalized as a subject for empirical study. I wonder whether it's preparatory for some sort of major National Academies of Medicine project, which would serve further to promote the practice. And again, some of these, to quote the philosopher John Rawls, are more political, I think you'll agree, than metaphysical. Language is important in these kinds of studies as well. The language we use shapes our attitudes and approaches to many issues, whether ethical or scientific. There is no scientific basis for deciding the terminology that we use. I'm going to use the term physician-assisted suicide here. The only science that might have been used is marketing science. What's going to actually promote this better? What terms can we use in that sense? And the terms that we use can obscure distinctions that are of ethical or even empirical importance. So, for instance, if you're doing scientific work, it's much better to be specific and say something like sideroblastic anemia than just say blood disorders as the subject of study. So from my perspective, the distinctions are really important between physician-assisted suicide, euthanasia, vigorous symptom control, foregoing life-sustaining treatment, all of which could, for a reasonable person, be included under the umbrella term assisted death, right? It's ambiguous that way. And again, I'd caution us about using terms that are more political in the way they are constructed than actually ethical or scientific. Community engagement, a real goal that anybody, any reasonable person would have these days. It's a new standard in human subjects research. This helps to shape the approach that we use and set the agenda. But of course, what are the questions one asks in community engagement, whether it's in East Africa or in the United States? It's which community and who gets to represent the community. And typically, the advice is one should avoid using advocacy groups as the group one engages for community engagement, or at least if you do that, be sure to be balanced. So, for instance, when I was on the Presidential Commission for the Study of Bioethical Issues and we were thinking about a study about incidental findings, we invited somebody whose incidental finding turned into an iatrogenic disaster, and then another person whose life was saved because somebody found something on an incidental finding on a scan. Here we have begun the entire proceedings with a spokesperson for an advocacy group. I don't think that that's really the kind of balanced, fair community engagement and objective scientific attitude that it should be typical of a real serious engagement with the questions. Study design obviously is important. You didn't hear reference to these, but there are lots of stuff in the literature about unscientific online polls, like the Medscape one, which is continuously saying that physicians are in favor of legalization of physician-assisted suicide. Well, I mean, it's an online, unscientific poll. It's continuously quoted. Nobody quotes the one from the New England Journal, equally unscientific, which reaches the exact opposite conclusion. We have small studies, such as Dr. Ganzini spoke about from state level, but the only national weighted probability-based random sampling study done by Farr-Curlin and his colleagues showed 69% of physicians opposed. That doesn't seem to get quoted. It is older, but it's the best study that we actually have of the issue. And then among the public, one is plagued continuously by ambiguous, complex, and leading questions. Like the Gallup poll that's continuously quoted says this: when a person has a disease and cannot be cured and is living in severe pain, all of which loads a lot into the question. Any scientific, bodily mindful person would recognize. Do you think doctors should or should not be allowed by law to assist the patient to commit suicide, right? In the Handbook for Engaging State Medical Associations, Compassion and Choices suggests that physicians who are members of these organizations not ask whether physician-assisted suicide should be legalized in their state, but should terminally ill, mentally capable patients have the option to receive aid in dying medication in cases of intractable pain or suffering. Not exactly an unbiased question, or one that purposefully invites some ambiguity. Second set of issues about study design, and a really important one, I think, is that if we're talking about the landscape, the way it looks depends on where you sit, right? If you're sitting in front of a desk in a think tank, or whether you're sitting in a wheelchair, matters in terms of looking at the data. And that's important as we think about this and about, again, who's represented. There are biases, certainly we heard some about, admitted by some of the investigators in recruiting subjects, particularly when it's done through political advocacy groups, when people have their own agendas and are not in any way representative of all dying persons who might be thinking about assisted suicide. There are biases in retrospective surveys of surviving family members. I think one of the strengths of Dr. Ganzini's work has been to show that she could find similar findings by actually talking to patients as well, but that's something to think about. And then the legal reporting mechanisms that we have, while it's certain that it's comparable year to year, has been purposefully made thin with the goal of protecting patient privacy, but it sort of gives the bureaucratic appearance of monitoring when it's self-reported, not really well validated, and we have no good data on unreported cases, and certainly from Europe, we know that unreported instances of these practices are great, or related practices. Data interpretation also is clear that the appearance depends on where you sit. Abuse is inevitable for any sort of law that we have. The question is going to be how much abuse of the law is too much. That is not going to be decided by the data themselves. It's going to be dependent upon people's attitudes, their ethical sensibilities in looking at it. Studies, we've been told, have shown that there is no slippery slope because the disabled and minorities are not overrepresented in those who are seeking assisted suicide. But that doesn't really answer the question, particularly from the point of view of those who are disabled, because for them, at least many of them, the fact that dependence on others becomes a socially sanctioned reason to be made dead is itself a threat to their dignity, even if they're not, themselves seeking it. We know that small numbers participate. I mean, the data have, at least in this country, confirmed that. But if this is really good care, what would be the problem with that? When you saw the larger numbers in Belgium, if you talk to the Belgian doctors, they don't think it's a problem that 5% of people are being euthanized in Belgium. It's a good thing. More and more people are getting access to this. So again, it depends on how you look at the question. The year-on increases in numbers, even though they're small in Oregon, to some extent show what's actually being promoted by Dr. Bach, which is increasing social comfort in prescribing and receiving these. Seems that it's a good thing. What does the pitch of the slope actually mean? That's not going to be answered by data. It's going to be answered by serious discussion from an ethical perspective, from a policy perspective. There's very little study, and then I was happy to hear Dr. Bach talking about it, of the psychological factors in this. Part of it is the psychological slippery slope for persons who begin to do this or see this as part of normal practice, and whether there is pressure on patients and practitioners to participate. As again, the Dutch are showing, patients coming to them, they have no idea would be qualified for it, asking and actually demanding that they be euthanized. And then you'll probably hear later this morning something about the logical and the slippery slopes, logical and legal slippery slopes, which are simply logical and legal and really not amenable to empirical study. They're just sort of what these sorts of practices imply. Above all, it's important for everybody in this room, particularly at a workshop like this, to realize that scientific facts are not ethical arguments. We've got to pay attention to what's called the naturalistic fallacy, or the fact-value distinction, the fact that you cannot derive an ought, what we ought to do, from a series of facts. Today's meeting, we are told, is not to discuss at length the moral or ethical arguments. And yet, I think everybody in this room has to realize that the topic is primarily of interest because it is ethically controversial. There'd be no other reason worth thinking about it. And to emphasize this, 4 days ago, all of the speakers were given a set of arguments for and against the practice, which have nothing to do with data. And in fact, there isn't a lot of data on the program here today, other than Dr. Ganzini's presentation. Good policy is based on both facts and ethics. Scientific facts themselves are not a policy argument, and I think in the end the data are not the primary issue here. We've got to keep that in mind even as we're looking at them and trying to figure out how they can be helpful. A little bit about some invalid causal inferences. The most common problem in medicine is post hoc ergo propter hoc. After this, therefore, because of it. Doc, they gave me the antibiotics and my cold got better, therefore colds cure viral infections. No, right? One that one commonly hears is, well, palliative care has improved in Oregon since the legalization of assisted suicide, and we're supposed to take from that somehow a causal inference, which one cannot have from that kind of data. It's not valid to say that. Another very, very common one is the argumentum ad populum, or because everybody says something is true, therefore it is. Ethical issues ought to be decided on ethical arguments and not by polls. There are also a significant number of pragmatic biases, and I think they may bring some of the folks into the room here. People who are saying, well, particularly physician researchers, this is legal, we just have to deal with it. It's inevitable, we just have to deal with it. The political effect of such a position is to promote the controversial practice. Laws can be ethically wrong. Laws can be changed. Ethics is about what to do, and what to do is up to us, said Aristotle. This is up to us to decide whether this is, in fact, a good thing and the way we ought to proceed. I'd remind you, too, a little bit about what I would say is a publication bias. Even prescinding from the actual positions that journal editors take in their editorials about the practice, there is a bias certainly towards what's new. And that means that the defense of the status quo is not new and just doesn't get published. And there's also a bias toward the empirical. And if you're going to study something empirically about assisted suicide, you're going to study assisted suicide where it's actually being practiced. And that gives the appearance, which one often reads then in editorials, that science and medicine are marching towards accepting assisted suicide. Be careful to make that conclusion from a reading of the volume of the literature because of these inherent biases towards the new and the empirical. So, what can we know, or what I think do we know? I think this basically dovetails with Dr. Ganzini's concluding slide. At present, the number of cases that follow the law is small, but they're increasing steadily year on and year out. Those who make the use of the law tend to be white, wealthy, and educated, and to have a distinct personality style that Dr. Ganzini described as dismissive attachment style, focused on control. There's a small but growing number of physicians who write the prescriptions. A substantial portion of the patients who seek this are depressed, maybe not overwhelmingly, but a substantial portion, and very few are ever sent for psychiatric referrals. The reasons that people seek this are not about symptoms, like the Gallup poll would suggest, but lost autonomy, loss of independence, and control. About a third of people die without taking the drugs, some because they die too soon, some decide not to use them. One, again, cannot assume that this means that they only wanted the security of having a way out. Those data cannot answer that question and shouldn't be used to support that. What are some of the gaps that I see that haven't been mentioned? Well, I'd like to see us do some serious deliberative polling, not just snapshots with loaded questions, but really having people understand what the pros and the cons are, what the alternatives are, and whether they want this. Something about the validity of the legal reporting, so that we have a better idea of whether those data are true or not. The prevalence of unreported cases, which we know in Europe is significant despite the law. More of the incidence of abuses. The psychology, as Dr. Back suggested, of participation by physicians. More about the psychiatric impact on families. There's some conflicting data, for instance, from Switzerland about post-traumatic stress disorder in families that have witnessed assisted suicide. The impact on the vast majority of patients who don't participate in this practice. More data about incomplete suicides and whether and how and where they are completed. More data about the effects on the generally psychiatrically ill patients. We have an epidemic of suicide in this country. We know, for instance, very early on that there are copycat suicides with more publicity about physician-assisted suicides. There are more copycat suicides among the mentally ill. And some emerging possible evidence about suicide contagion, both in the US and in the Netherlands. Some criticisms of that literature. It would be good to do more to see whether those preliminary studies are true or not. And then I just suggest to you as a thought experiment, if this is just normal medicine, why aren't we doing randomized controlled trials, right? To find out how well we and efficiently and cost effectively we can do this. And if that is disturbing, then maybe it would be a good study to find out why. So, thank you.